Good morning, everybody. Today we're going to be talking about alterations in musculoskeletal and the integument system. As we are covering two systems, we are going to primarily focus on the pathophysiology of some selected disease processes in both of these systems. We'll start with rhabdomyolysis. This can be a life-threatening complication of severe muscle trauma. This is related to the release of myoglobin from striated cells. So whenever you have cells that are either over-exercising or they're injured, they will release myoglobin. If there's too much release, then this can lead to renal failure in the kidneys. This is usually caused from either a crush syndrome, from some kind of significant injuries, compartment syndrome, but it can also be caused from over-exercising, especially in individuals who are deconditioned, or somebody who does something like run a marathon or something of that nature. Hydration is really important in preventing this. So you will see this sometimes in the summer when people are not drinking enough when they're exercising. The myoglobin will affect the kidneys and can lead to renal failure. So basically all you can do for it is kind of wash it out with fluids. A common thing that you will be treating in the primary care setting more, whereas rhabdo is more in the acute care setting, but in the primary setting is osteoporosis. Osteoporosis really, we are constantly reforming bone, and we think of bone as kind of static in there like a piece of wood, but it's not. It's constantly being reabsorbed, broken down, reabsorbed, and reformed. When you get an imbalance between that formation and bone reabsorption, that's what occurs with osteoporosis. And you end up getting very porous bone that's not mineralized well, it's not very dense and not very strong at all. Risk factors for this, one is sedentary lifestyle, immobility. And the reason that these are risk factors is because being active actually promotes osteoblast activity. So when you're active, it helps you to, in weight-bearing exercises, this helps you to form new bone. In addition, diets high in alcohol, caffeine, or low calcium, low vitamin D can also contribute. Smoking is a risk factor. Postmenopausal women are more likely to have osteoporosis, and women with a very small bone structure, Caucasian and Asian females. There are certain medications that can increase the likelihood of lead to osteoporosis as well. Pathophysiology, of course, one of the things that happens is you have a decreased levels of estrogen and testosterone, and these lead to some imbalances. One of those, rankle, is a hormone that is produced by osteoblasts, and it activates RANK. RANK is a receptor on osteoclast, and when it's activated, this promotes osteoclast differentiation. So in other words, when your osteoblasts are busy making new bone, they activate rankle, which in turn will activate osteoclast, because at the same time you're making new bone, you also want to be breaking down old bone. OPG is a receptor protein that acts as a decoy receptor for rankle. So again, it's while you want osteoclast to be active, you want rankle, you don't want too much. So it's when these get imbalanced and out of whack that you begin to have more bone breakdown than bone formation. And it's also due to the testosterone and estrogen, you have decreased osteoblast activity in general. Other things that contribute, we talked about the decreased activity level, which will decrease osteoblast activity itself. And then inadequate nutritional levels of vitamin D, C, and magnesium can also contribute. Secondary osteoporosis can be from endocrine disorders, from malignancy, too much alcohol consumption, and some medications can lead to that as well. Your clinical features, I mean, in the beginning, this is a silent disease. But as time goes on, you began to see some effects of this. I want to back up just a minute. This shows you a picture of the difference in bone, normal bone there on your left versus the very thin, frail, not very strong bone on the right. As this disease progresses, what you will begin to see a loss of height. You'll begin to see fractures, both fractures from fall, but pathological fractures as well. A pathological fracture occurs when somebody has a fracture, but no significant injury that would cause one. I've seen somebody break their hip when they sat down on the toilet. Your common fractures are the distal radius, vertebral compression fractures, and hip fractures. Individuals also develop this kind of humpback, the Staudinger hump, who have osteoporosis. We begin scanning women at age 65 and men at age 70, but we do it earlier if they have some increased risk. Treatment of osteoporosis, the most first-line treatment is biphosphonates, and they prevent they inhibit osteoclast activity. Other things that we do, there's selective estrogen receptor modulators that reduce the reabsorption of bone and decrease that turnover. Other things are things like calcitonin, which blocks bone reabsorption. Recombinant human parathyroid hormone will stimulate bone remodeling. There's a wrinkle inhibitor, which is another option, and we also give calcium and vitamin D supplementation. Another disease of our bone is Paget's disease. Paget's disease is excessive reabsorption of spongy bone. And then you absorb this spongy bone, but you replace it with this very soft bone. And so what happens is you have this osteoclastic bone reabsorption. So you're absorbing bone, and then the osteoblasts go into place, but it's very chaotic bone formation, very disorganized. So you end up having this thickened bones, but they're soft. They're not good. This mostly affects the axial skeleton, so the quality of the newly formed bone is very poor. The bone marrow itself is results in loss of connective tissue. And so you'll see these thickened bones, and this can cause abnormal bone curvatures, can cause brain compression, impaired motor function, deafness, and even atrophy of the optic nerve. Mostly affects the exoskeleton, the femur, and the tibia, but you'll see it again in the skull and other places as well. This is just kind of a picture of some of the clinical manifestations of Paget's disease. You can see that thickened skull in the front. Again, if it's early on, this may be asymptomatic. But you'll see a thickened skull, and you'll see this, their jaw, clavicle, long bones will get thickened. They can develop kyphosis. Their femurs and tibias can bow. Eventually, they will have pain. Because of this, they're having this very fast, chaotic bone reformation. They get a lot of vasculature in that area. So a lot of vasculature bringing in nutrients for this chaotic, fast bone reformation. And this can actually increase their risk of developing sarcoma. Another bone condition is osteomalacia. And this is due to a deficiency of vitamin D, which lowers the absorption of calcium from the intestines. And so you will get your bone as it's forming, the mineralization, the part where you lay down the strong part of the bone, will be inadequate or delayed. The calcification doesn't occur. And when that doesn't happen, the result is very soft bones. And these individuals will present with pain, Also with fractures, their vertebra will collapse, their bones will be malformed. Another thing you will see is osteomyelitis, which is an infection in the bone. Your most common cause is staph. This can occur exogenously from an open wound. We'll see this often with diabetic foot ulcers and things of that nature, but it can also happen endogenously from a blood-borne infection. They will get acute and chronic inflammation, fever, pain, and necrotic bone. Your treatment for this is antibiotics, debridement. They may have to have surgery to have part of this removed if those don't work, and a hyperbaric oxygen therapy. Pathophysiology, as the infection multiplies in the bone, it causes inflammation and an immune response. The phagocytes attempt to contain the infection and release enzymes, but these enzymes that they're releasing to contain the infection also will destroy the bone. So they contribute to the degradation of the bone. So you'll get your normal signs of infection: pus in the bone, edema, a lot of vasculature congestion. And it's really that this pressure from the edema that compromises the blood flow, and that leads to the ischemia and the necrosis that develops. This is just kind of a picture of what happens when you have osteomyelitis. You have this initial infection, which may be mild, but then as you get all of this swelling, all this pus, maybe an abscess forms, that's when you start blocking the blood supply. And so what happens is that your body will kind of sequester the dead bone, kind of sequester it. And then you may have new bone that forms around it. So let's talk about joint diseases. We have both inflammatory and non-inflammatory diseases. You differentiate these by, is there synovial membrane inflammation? Are there systemic signs and symptoms? And what does that synovial fluid actually look like? Osteoarthritis is a non-inflammatory condition. It is, the bone will degenerate. You will lose your articular cartilage. As the damaged cartilage tries to repair itself, it will then actually lead to the formation of bone spurs or osteophytes. The cartilage will become very weak, rough, eroded, and will no longer protect the surface of the bones. This increases with age. It's just a primary disease. The joint stiffens on movement, and there is pain with weight bearing with this disease. It's usually relieved by rest. There's stiffness, there's enlargement of the joint itself. It may be tender, but it's not inflamed. And there'll be limited motion and deformity that occurs. Now, rheumatoid arthritis is an inflammatory joint disease. What happens is there is immune complexes that form. Remember these antibody-antigen complexes, and they are deposited in that synovial space. And that's where the whole problem starts. While the symptoms are similar, there are some differences, but when you're looking for it, you will see a presence of rheumatoid factors that'll be present that normally would be negative, and the fluid will present with exudate. If you do a synovial, if you pull synovial fluid out the joint, it will present with an inflammatory exudate. This is just showing you kind of a little bit about what happens, but as that antigen's released, remember this is an autoimmune disease. It activates both B lymphocytes and T cell activations. And remember, when you look over to the far right, those leukocytes, one of the first things that happen, they enter that synovial membrane and lead to phagocytosis and release of the enzymes. And these enzymes actually cause part of the joint destruction and the issues with the cartilage. Also, the T cells affect wrinkle, and so your osteoclasts get activated. You'll get a lot of, this whole inflammatory response is what happens with rheumatoid arthritis. This is just a picture of the rheumatoid arthritis is a systemic disease. It doesn't just affect the joints, so that's primarily what it affects, but this whole process can also affect other organs. There's some eye lesions that can occur, lymphadenopathy. People can develop pericarditis, nephropathy, pleural effusions, vasculitis. You can see anemia and splenomegaly with this as well. And usually these individuals are very tired and weak and may even develop anorexia. Gout's another inflammatory disease. It is really a metabolic disorder that disrupts the body's control of your uric acid production and secretion. You will see higher levels of uric acid in the blood and other body fluids. And when the uric acid concentration increases enough, it will actually crystallize. And these crystals deposit in connective tissue throughout the body. And when the crystals occur in the synovial fluid, that is when you get the arthritis that occurs with gout. Gout is usually related to purine metabolism. And so affected people can have an accelerated synthesis and breakdown of purine, leading to poor uric acid secretion in the kidneys. When the crystals are deposited, they're more likely to be deposited at lower body temperatures if they have decreased albumin or trauma. That can lead to the crystals being deposited more. When you're looking at purine, high purine foods, you want to avoid these. These include things like organ meats, any meats, alcohol, seafood, asparagus, mushrooms, beans. So there's a whole list of high purine foods you can look at. Most people who have gout is related to the kidney's inability to eliminate the uric acid efficiently. That accounts for about 90% of gout. About 10% is overproduction of uric acid. In the clinical stages of gout, you're going to start out first with asymptomatic gout. You won't even know you have it. But if you check their urine, they would have, or their blood, they would have high levels of uric acid. Eventually, then they will begin to get gouty arthritis. And then as deposits increase, you'll get the tophi that will develop, the deformities that will develop secondary to untreated gout. Fibromyalgia is a common thing that you will encounter in the primary care setting. It's characterized by widespread joint and muscle pain. It is often co-diagnosed with chronic fatigue syndrome in about 70% of cases. In order to diagnose it, they have to have at least 3 months of pain, and you have to rule out other causes. The symptoms are vague, but they do have increased sensitivity to touch. There's no inflammation present that you can see. They are very tired, and there's sleep disturbances with it as well. It's a diffuse chronic pain, often described as burning or gnawing pain at tender points, and there, again, very profound fatigue occurs with this. We have yet to determine for sure the cause of fibromyalgia, but we know it's related to often to some flu-like viral illness. It occurs after this. Things like Lyme disease, HIV infection also contribute, physical and emotional trauma as well. So we're still studying that. These are some of the tender points. that they have identified with it, but overall, these people just hurt all over. We found a lot of COVID conditions with fibromyalgia. Often there's some depressive disorders present. They may have some rheumatological diseases as well. Headaches, joint pain, fatigue, all of those are kind of comorbid conditions that occur with gout. With fibromyalgia. Let's move on to children. Just a reminder, until the adult statute, till their total height, they get to their final height, bone growth continues to occur. It occurs at the epiphyseal plate through some endochondral ossification that occurs. Once the epiphyseal plate closes, you will see the metaphysis and the epiphysis will unite. This does occur earlier in females and males because puberty occurs earlier. And, the understanding whether the epiphyseal plate is closed or not, that can help you determine your diagnosis. Some factors that affect bone growth, one is growth hormone. We know you can have too much growth hormone. This is secreted by the pituitary, or you can have inadequate growth hormone. Good nutrition, just general good health. And there's a lot of other growth factors too, like fibroblast growth factor. There's a lot of things that go into the formation of bone and specifically to growing bone. In children, muscle development continues to occur between birth and maturity. The amount of muscle nuclei in the body increases 14 times in boys and 10 times in girls. And this will kind of vary with age. One disorder is osteogenesis imperfecta. This is brittle bone disease. It is due to a defect in collagen production. And it results in severe osteoporosis, really bowed and deformed limbs, a very short stature, curved spines. You can find this evident sometimes before birth. You'll see in utero fractures. These individuals are very easily can fracture these children. If it's a very severe case, the child may be stillborn or die soon after birth due to just huge amounts of intrauterine fractures. Of course, if they identify this in utero, they will do a C-section to prevent you can imagine of how many fractures would occur just during the birthing process itself. If it's a milder case, it may not be diagnosed until the child begins to walk and they start having little fractures. And it can often be mistaken for child abuse. This is just a picture of a child. You can see the bowing that occurs here of the legs secondary to this. It's really a very sad disease. Another disease of children we don't see often is rickets, and this is usually due to the insufficiency in their diet. And this is the disorder causing soft bones. They don't mineralize well, so you end up with skeletal deformities, so they don't harden. Usually this is from either their body doesn't work well with vitamin D, it doesn't sensitive to it, it doesn't absorb it, or they don't have enough, or they get rid of too much in their kidneys. They will definitely present with the bowed legs, soft bones. They're unable to kind of hold themselves up well, so their bones will bow out. Scoliosis is another pretty common disorder of childhood. It's when you have a rotational curvature of the spine. Typically, what we see is the structural form of the curvature is associated with this vertebral rotation. And it's associated with skeletal deformities. It can also be associated with trauma, with bone infections, metabolic bone disorders, but it can just happen in of itself. There's several forms of scoliosis. This is just showing, milder versus very severe forms. In a very severe case, it actually can cause respiratory complications because of the inability for the lungs to expand properly. Another thing you may see is juvenile RA. This is a childhood form of rheumatoid arthritis. The pathophysiology is the same, but it often will occur, you'll see it in more joints at one time. And it is they definitely have a more rapid onset. And it's definitely, they will have systemic manifestations earlier. The difference in juvenile versus adult, in adult RA, you'll see the small bones affected quicker, but in children, the large joints are affected. You can see issues with the cervical spine. The joint pain is not as severe, but they can also develop some of the systemic things such as the chronic uveitis. They don't always have a positive rheumatoid factor. But they can get rheumatoid nodules in heart, lungs, eyes, and other organs, while their subcutaneous nodules will not be as evident. Another disease is osteochondrosis. This is a vascular disease of the bone. Another name for it is another form of this is leg calf Perth's disease. Two forms of osteochondrosis. One is leg calf Perth's disease. Another one is Osgood-Schlatter disease. Leg calf Perth's is more common in boys ages 3 to 10, and it's results from a interrupted blood side of the femoral head. It is usually a self-limiting disease, but it can cause deformities due to ischemia can be permanent. Another one is Osgood-Schlatter disease, which is tendonitis of the anterior patellar tendon, and osteochondrosis of the tubercular of the tibia. This is just a picture of what happens with leg calf Perth's disease. Basically, you end up getting a necrotic bone that forms past. There's usually some kind of cyst formation. You get some necrotic bone, and then as it resolves, the bone does regenerate, but sometimes you end up with some deformity secondary to this. Cerebral palsy is another muscular disease of childhood. It's a disorder of muscle tone and balance. It's caused by ischemia, usually in the perinatal area time frame. This can lead to hemiplegia, quadriplegia, and much milder forms. Some people with cerebral palsy just have issues with gait, doesn't affect their mentation at all. Muscular dystrophy is one more. This is a group of disorders that cause degeneration of the skeletal muscle fibers. They cause progressive systemic weakness and wasting of the muscle groups. Duchenne's is the most common and the most severe. It's an X-linked disorder that occurs in 1 in 3,500 males. They lack dystrophin, dystrophin actually protects the muscles from mechanical stress, and these individuals lack this. Other forms are Becker's and limb girdles, but the most common one you'll see are Duchenne's. Other things you may see in children are bone and muscle tumors. There's a variety of them that you will see. There's some are benign, some are malignant. Osteosarcoma is the most common malignant tumor of children. and it often will metastasize to the lungs. Approximately 25% will have lung mets at diagnosis. This usually occurs at the metaphysis of the long bones, and this kind of shows you an example of that. Ewing's sarcoma is the most lethal bone cancer in children. It often occurs mid-shaft of long bones or the flat bones, so the pelvis, the femur, the tibia. Rhabdomyosarcoma is one other. This is a muscle tumor that can develop anywhere in the striated muscles. This most common area actually is occur in the orbital area. So these are just some examples of some tumors and things that can happen that are more common in children. Next, we'll move on to the integumentary system. We're going to talk first about inflammatory disorders. Dermatitis or eczema is really the most common. There's various forms of this. It's characterized by these lesions with these indistinct borders, changes in the epidermis, and by pruritus. Allergic contact dermatitis, this is usually, remember, your hypersensitivity reactions. This is usually a type 1 and type 4. The type 1 is IgE mediated, or the type 4, remember, is T cell mediated, and that is like poison ivy or being allergic to metal. What happens is the allergen comes into contact with the skin. It then binds to the carrier proteins to form an antigen. These linker cells process the antigen, carry it to the C cells, and then become sensitized to it. And you will see this erythema, swelling, pruritus, and vesicular lesions with that. This is just an example. Another thing you'll see commonly is atopic dermatitis. This is definitely a type 1 hypersensitivity, activation of the mast cells, eosinophils, T lymphocytes, and other inflammatory markers. This is what we call eczema. It causes red weeping crust, chronic inflammation of this area. This is the most common form of eczema in children. It can lead to lentification, which is a thickening and hardening of the dermis. There's also irritant contact dermatitis, which is not an immune issue. It's usually just a chemical irritation that occurs. The symptoms are similar, but basically you just have to remove the irritant. This is like maybe something in your clothing or something you've been exposed to. This is a picture of atopic dermatitis. There's also stasis dermatitis, which occurs in the legs. It's usually as a result of venous stasis or edema or vascular trauma. You'll see this stasis dermatitis in people with vascular disease. There's an erythema, pruritus, eventually scaling, petechiaform, and eventually ulcerations. Another one is seborrheic dermatitis, which is an inflammation of the skin and the scalp. Usually it can be in the eyebrows, the nose, but it's on the head. And it results in scaly white or yellowish plaque or dandruff. Papulosquamous disorder, the most common we see is psoriasis. And this is a chronic relapsing skin disorder. It's a T cell mediated. And you will see what happens is the epidermis, normally our epidermis will turn over every 26 to 30 days, but in psoriasis, it turns over much quickly every 3 to 4 days. So you end up seeing this really scaly, thick, silvery, elevated lesions that can be on the scalp, elbows, knees, a lot of different places. But the cells don't have time to mature properly because they're constantly turning over. This is a picture of psoriasis. There's different forms of psoriasis. You can see there's some very severe forms that have pustular psoriasis. What we normally, the most common we see is plaque psoriasis, which is, that's kind of picture of what you see here, but there are some very severe forms. Fungal infections are not another common thing that can affect our skin. They can lead to some superficial skin lesions. You'll treat this a lot in primary care. There's different forms, and these little mycosis that form are termed tinea. So we see different forms of tinea. We can see tinea capitis in the scalp, tinea pedis in the athlete's foot, on the skin, corporis, which is ringworm, in the groin area, and the nails. All of these are forms of fungal infections. And this is a picture of ringworm on the right, tinea pedis or athlete's foot on the left. There's also some vascular disorders of the integument. Cutaneous vasculitis. This is an immune issue where you have the immune complexes in the small blood vessels form. This can come from infections, allergens, or from drugs, and they'll get some purpura progressing to hemorrhagic bulli, and eventually will have necrosis and ulceration from this. This is a picture of cutaneous vasculitis. Urticaria or hives is another common one. This is an IgE type 1 hypersensitivity reaction due to release of mast cells and histamines. The histamine release causes the endothelial cells of the skin to contract, and you get leakage of fluid. You treat this with, of course, antihistamines and steroids, and this is a picture of that. Scleroderma is a chronic progressive skin disorder of the skin, and it also affects the internal organs. They will get massive deposits of collagen, inflammation, vascular changes. And what happens is the skin becomes very hard, it gets hypopigmented, it's very tight, and it gets very tightly connected to the underlying tissues. There's several antibodies implicated in scleroderma. Your face will get very tight. The mouth may not even open completely. 50% of patients who get this die within a year. This is just a picture of a hand of somebody with scleroderma, and you can see how the skin's kind of tight and taut. As this progresses, though, it affects the skin all over, but also the collagen. This is a systemic disorder. The collagen is deposited in the other organ, many organs, and can lead to a host of systemic issues. There's also some tumors of the skin. There's some that are benign. On the top right, you see seborrheic keratosis. The bottom left is keratocanthoma. And the bottom right is actinic keratosis. You look at these and you think, oh, these might be cancerous, but these are all benign conditions. Cancers of the skin, we have several common kinds, basal cell carcinoma. In these kind of skin conditions, you get a depressed center, and the borders kind of roll back. So the center often has a little ulcerated area. They're usually on the face and neck, and they're very slow growing. Squamous cell carcinoma is also common on the head and neck, and it's usually more elevated, and they do bleed easily. Malignant melanoma is usually from a mole. And Kaposia sarcoma is a vascular malignancy associated with AIDS. They will get purplish brown macules that develop into plaques or nodules, usually present on the upper body and the face. These are some pictures of these different types of, this is a picture of melanoma. and the different ways that it can look. You're going to see with any kind of skin cancer, you're going to see asymmetry of the lesion. It may not match in color. The borders are not distinct. They're not nice and smooth like they are in the pictures on the left. There's color variation, and if it's larger than a pencil's eraser, we do begin to look at it more carefully. These are pictures of those other carcinomas we looked at. If you start at the top left-hand corner, that is the basal cell carcinoma. The next one is Kaposi. And the next one is melanoma. And the next one is, on the bottom left is squamous cell carcinoma. Children also have some distinct common skin conditions they get. Of course, one of these are these infections of the skin, are very common in children. Most common in children, these fungal infections are tinea capitis or scalp, cradle cap, athlete's foot, and ringworm. This is a picture of tinea capitis. This is the most common fungal infection in childhood. Usually they get it from a dog, a cat, or certain rodents. You can also get fungal infections of the mouth. Thrush is one. This is when you have Candida present in the mucous membranes of the mouth of infants. It's less common in adults. They'll get white plaques and maybe little ulcerations. You can also get this in the gourd, buttocks, and other parts of the body. Very hard to feed when you have this. There's some viral infections. The most common one in childhood you'll see is molluscum contagiosum. This is a very contagious pox infection of the skin. It is transmitted via skin to skin or fomite transmission. Fomite is things like such as clothing or towels, etc. The virus encourages epidermal cell proliferation and kind of blocks that immune response. It is not painful, but it often itches. It's also associated with immunodeficiencies in some instances. And this is a picture of molluscum contagiosum. It's viral. You'll see there's no inflammation around the lesions. Lesions most commonly occur on the trunk, face, and extremities. Chickenpox, of course, is another, and herpes are two other viral infections produced by the same virus. This is the DNA virus. This chickenpox is a real discrete rash. It will begin to spread rapidly over the trunk. There's less so on the, not quite as much on the extremities. Herpes zoster can present in children. We most commonly see it in adults, however, but I put it here just because it goes with chickenpox. This will form a skin lesions along a dermatome. It can be itchy, but it can be extremely painful. We now have the zoster vaccine for adults 50 and over, which can be really helpful in preventing herpes zoster. The neuropathic pain associated can last much longer than the skin rash. You often see some, insect bites and parasites can affect the skin often in children. Scabies is one caused by the itch mite. It's transmitted by either personal clothing or infected bedding. So the female mite will tunnel in to the skin and deposit the eggs, and then the eggs then mature into adult mites. So you're going to see these burrows and papules and vesicular lesions and severe itching with this. The patient is at risk for secondary infections from scratching these very itchy lesions. This is a picture of an infant with scabies. And this is what, if you actually scraped one of these up and put it under the microscope, that's what it looks like. Another thing that you see in children often is pediculosis. This is when you have a parasite that actually sucks the blood, like a tick. You'll see it in the or lice, like lice. You'll see it in the head, that's lice. You can see body lice, which is pediculus corporus. And then you can also see it in the pubic area. And again, the female louse reproduces every 2 weeks and will produce hundreds of eggs. You get this through personal contact or combing, sharing brushes or combs or clothing. Flea bites is another thing you'll see often in children from cats and dogs. They usually occur in clusters. And that's kind of what they look like. Bed bugs are another thing. They live in the crevices and cracks of the floor and walls and furniture. They're 3 to 5 milliliters long, kind of reddish brown, and they do feed in the darkness. So they'll attach to the skin, suck the blood, and then they leave in the morning, leaving you with these lesions, which are macules, but can develop into nodules. And this is a picture of an infant with bed bug bites. There's also some benign tumors of the skin. One is, these are hemangiomas. They occur from rapid growth of vascular endothelial cells and formation of a lot of extra blood vessels. Females are more likely to have these, and there's superficial ones, which we call strawberry hemangiomas, and more deeper ones, which are cavernous hemangiomas. They feel like that there's embolization of fetal placental endothelial cells. This can be related to either placental trauma or loss of placental or loss of a inhibiting factor. The strawberry hemangiomas, you'll see a raised vascular lesion that emerges 3 to 5 weeks after birth. The lesions will proliferate and become bright red, and they will elevate with a lot of capillary projections. Cavernous hemangiomas are present at birth. They involve larger and more mature vessels. This is a picture of strawberry hemangiomas and cavernous hemangiomas. Another vascular thing you will see on the skin is port wine stains. These are congenital malformation of dermal capillaries. They are flat, pink to dark reddish purple lesions. We also see salmon patches, which are pink lesions that result from distended dermal capillaries. They usually fade by 1 year of age. We call these stork bites on the nape of the neck, sometimes on the forehead, other places. This is a picture on the left of port wine stain, on the right are salmon patches. 95% of salmon patches do fade by 1 year of age. And that is all for today. Let me know if you have any questions. Thank you.